Good afternoon. I'm Dr. Anthony Levinson. This is my colleague, Dr. Richard Stramko from McMaster University, and welcome to our 6th live event as part of our iGeriCare series. Today's live event is on the topic of medications and dementia. I want to remind people they can access the live event through igericare.ca/events, also through our Facebook page. Our goal today is to keep today's session to about 45 minutes. If you can't stay with us for the whole session, we will always post these recordings after a few days on the iGeriCare events page. So thanks very much for joining. You can send your comments and questions through our events page or through Facebook. And we also had a few that were posted after our last live event that we'll try and cover today as well. If we don't get a chance to answer everybody's questions, apologies in advance. We'll sometimes record an extra session where we answer them, or we try to answer some in text form by responding to them. Okay, so why don't we start off with just some basic background about the role of medicines or treatments for dementia? Probably important to get a few basic concepts right on that.
Sure, I think that's a great place to start. So oftentimes when we are thinking about medications, we put them into several classes. So one is, do the medications actually change the course of an illness, or are they disease modifying? So if I gave somebody a medication, could I cure their cancer by giving them that medication? Or could I get rid of their rheumatologic disease or their joint disease by giving them a medication? Versus, can I treat their symptoms? Can I manage somebody's pain? In the setting of dementia, we often talk about behavioral symptoms or boosting somebody's memory and thinking capacity. So a good place to start with dementia is that there's no treatment that's a disease-modifying therapy right now. And we covered that in the lesson, how dementia is treated. There's a few things that have been tried for Alzheimer's that has these toxic proteins, beta amyloid and tau. We've tried medications that attach to those molecules and try and get them out of the brain. We've tried vaccines to try and get those molecules out of the brain. There have been many different strategies employed to help the brain heal itself and get rid of these bad molecules. And unfortunately, to date, there's been nothing that's been proven to slow the progression of disease or get rid of the actual underlying process that causes Alzheimer's disease.
So no cure, and really more experimental treatments, continuing to look for disease-modifying treatments, but
absolutely,
really at an experimental stage right now. So what does that leave us in terms of the treatments?
So now we're into the realm of symptom management. Okay. And in this case, the target symptoms that we're trying to address with the medications are, can we improve your thinking ability somewhat, or your cognitive performance across the domains we've discussed previously and that are noted in the actual lessons themselves? If you're having agitation or aggression or having some psychiatric symptoms associated with it, such as depression, anxiety, or apathy, can we improve that somehow? Is it possible? A big thing that we notice as dementia progresses is that people lose their ability to function in their environment, doing their shopping or cooking or cleaning around the house, things like that. So is it possible for us to give a medication and improve their ability to function in their environment day to day? And that's the realm that we're looking at then.
Yeah, and in the psychiatric symptom world, people will sometimes try medicines for the treatment of anxiety or depression or psychotic symptoms like delusions or hallucinations in the context of the various dementias. And, you know, I think it's I don't want to say it's completely demoralizing, but there is not great, strong evidence for the role of medications and even for symptom modification. In many cases, non-medication approaches would still be the better place to start. Is that fair to say? Absolutely.
I think the important thing to note about the medications, and we can break them down across their classes. So are we talking about a cognitive enhancer, which improves cognitive capacity? Are we dealing with just the psychiatric symptoms? But absolutely. I think a non-pharmacologic, non-medical approach is always the best place to start, and then adding in medications. And also, for people to have realistic expectations around the medications that we're prescribing. They're not a miracle drug that's going to cure everything. They have what's called statistical significance, and that there's a small difference. It's clear across studies that yes, they do work, but the actual size of the effect, it's not. None of them are very large effects.
I think we could talk a little bit maybe later on about some of the clinical pearls or tips that we might say, because I think one of the things that we often see in medicine generally is people will start a medicine to try to help with a symptom, and even if it's not helping that much, or it's not helping at all, or the person's having side effects, sometimes they just keep getting the medicine prescribed. And we certainly see in people with dementia or older adults this accumulation of different medicines that, maybe 2 years ago somebody prescribed it as a short-term treatment for insomnia, and they keep on keeping on, and before you know it, you have 3, 4, 5 medicines that may or may not be that effective. So it's really important, and I think you and I both do this quite a bit, to focus on de-prescribing sometimes. So
absolutely,
one of the things you can do as a caregiver is advocate for your loved one and really bring that list of medicines and say, hey, are all these really necessary? Which ones are working? In today's live event, before we get to the questions too, we did want to talk a little bit about some complex anatomy and how some of these medicines work, because it can be important for understanding the other side of the coin, which is when medicines and their side effects or adverse effects might be making cognition worse in somebody with dementia. So let's spend a couple minutes talking about that, and then we've got quite a lot of questions coming in, which is great, so we'll hit those in a moment. So at the risk of bamboozling people with terminology, I'm going to cover a couple of the concepts and bigger words that we're going to be talking about. And I think it's important. We will be simplifying things, but I think we want people to understand enough to make sense of how some of these medicines work and how some of the other medications, including over-the-counter ones, might cause bad side effects for people with cognitive problems like dementia. So one of the heroes of our story is acetylcholine, which we're going to call ACH. And you already referred to one type of drug, which is cholinesterase inhibitors, or CIs. And we do talk about that in the lesson on treatments. And one of the evil characters in our drama today are anti-cholinergic drugs, or anti-ACH. These are medicines who have, as one component of how they work, blocking of acetylcholine or ACH. So let us move now to our diagram. So this is a very simplified diagram showing an imagined connection between two neurons or nerve cells. This is very simple because it turns out there's hundreds of millions of these guys in the brain, and there's a lot we don't understand about the brain. But here's what we optimistically think we do understand. Memory cells in various parts of the brain, including the centers that seem to be most responsible for memory and often most affected by dementias like Alzheimer's, they seem to rely heavily on ACH for the communication between those nerve cells. And that seems to be very important in the function of memory. So back to how our CIs, or cholinesterase inhibitors, work. In this middle part, where the ACH is traveling from one nerve cell to the other to maybe strengthen or enhance memory or communicate a memory, the role of the CI is to actually block the dissolving of the ACH, keep it in the synapse for longer so that there can be more communication between those nerve cells. So So that's kind of the role at the chemical level of the CI, to make more ACH, more acetylcholine, available for neurotransmission, because in many of the dementias, there's a death of these cholinergic or ACH cells, and we think that plays a really important role in the decline of memory. Now, remember we were talking about the evil anticholinergic or anti-ACH. It turns out that many, many medicines block these receptors on these ACH neurons. And these can be, think of so many medicines, both prescription drugs and over-the-counter drugs. So a drug like Gravol or NyQuil, drugs that people take to help with them sleep, these drugs often have anticholinergic side effects. Drugs to help with bladder control that are often prescribed. Again, lots of anticholinergic side effects. And one of those side effects, because of the effect on these ACH nerve cells, can be worsening memory. So you and I have probably both seen patients on various anticholinergic medicines who look like they have a dementia, or maybe they have a dementia and it's gotten worse since those drugs have been prescribed. Is that fair to say?
That makes sense. That's always the first step. If there's something you can reverse or take away before adding anything on, especially when they're medications that have known cognitive side effects, then definitely get rid of them. So,
important to bring that full list of your medicines to your pharmacist, to your family physician, if you're fortunate enough to have a geriatrician or a psychiatrist. And one of the things they'll be looking for is to see whether or not any of the medicines you're taking are interfering with this system in some way. So that's kind of our quick overview of the ACH system and why cholinesterase inhibitors may help to boost that system, and how anticholinergic medicines and drugs that have anticholinergic side effects can sometimes cause cognitive impairments through that mechanism. Okay, shall we go to some questions for now? Here is a good one and a complex one. I'm gonna pick a simpler one to start. So here's a good question from Toronto. What is your recommendation for medical marijuana for an 80-year-old with dementia and severe arthritic pain?
I think it's complicated because there's not a lot of science to back up treatment of people that have dementia. And I think medical marijuana in general is an evolving field, and one that we don't have a lot of hard and fast answers for. And so one is there any evidence for treatment of pain associated with, joint pain with medical marijuana? And then could the people that are older that have cognitive impairment be more susceptible to side effects? So I've been kind of staying away from that, especially if the tried and true methods haven't been used first. So regular use of Tylenol on an ongoing fashion is a better treatment because of the lack of cognitive side effects, or using something like Voltaren, which is an anti-inflammatory cream, and then gradually stepping up to using maybe a by-mouth medication, anti-inflammatory. But that wouldn't be my first step. I would probably try the tried and true methods that we know that don't have cognitive side effects, and using the lowest dose possible for any drug that you would use to control pain in that setting. And I don't use medical marijuana in my practice currently because of the absence of evidence, especially amongst cognitively impaired individuals.
So I will totally agree with you. What I would say is right now there is no evidence for cannabis, THC, CBD in the treatment of dementia or the use of or help with managing the symptoms. There are some studies underway, but if you look at the quality of the current scientific research on this, there is not enough evidence to recommend cannabis in somebody with dementia. Secondly, cannabis would not be a first or a second or a third line treatment for arthritic pain. it's a third-line treatment for what we call nerve pain or neuropathic pain in the setting where somebody has not responded to at least 3 of the first or second-line treatments. So we actually had a couple of other questions related to cannabis, and we'll cover those off. But I think maybe you could say the jury's out with respect to some of these trials looking at whether it may be helpful and not harmful. But the current state of evidence would say I would not recommend cannabis in this setting. So,
and there's nothing to say that this knowledge set won't evolve over the next few years. Maybe somebody will do a well-designed randomized clinical trial in this setting and it will prove it. But right now,
yeah, there's a very good researcher doing work at Sunnybrook, and I think there's been some encouraging results with certain cannabis-related products, but again, small studies, and really not one where you'd say, oh, let's try this first, kind of thing. Does it make a difference what kind of dementia a person is suffering from? So there's a question from Calgary. And I guess I'm not sure whether it's a question specifically related to whether it makes a difference in terms of the medications used or maybe a more general one. So do you want to answer it in a general way first, and then maybe specifically we'll talk about medicines?
Sure. I mean, it does because people like having, I think first of all, people like having a specific diagnosis. It's hard just to say that you have dementia and then the family has to go and read through, well, do I have dementia with Lewy bodies? Do I have Alzheimer's disease? Do I have Parkinson's disease dementia? That's too overwhelming. So it does matter because the different dementias have different symptoms and different physical examination signs that we should be able to be fairly specific about. So I think that's the first step. The second step is that they all have different pathology, meaning the insult that's happening to the brain when you look at it under a microscope is very different. So the toxic protein that we've described previously in dementia with Lewy bodies is called alpha-synuclein. I know it's a complex technical term, but that's much different than the tau and beta amyloid that you see. And so if you were trying to treat those diseases with disease-modifying therapy, you would certainly want a different approach because they're different diseases. The next step is when we're talking about treatment with, let's say, a cholinesterase inhibitor trying to boost the levels of acetylcholine or ACH to improve cognitive function, Alzheimer's disease definitely has a lower level of acetylcholine than some of the other dementias. Dementia with Lewy bodies probably has the lowest amount of acetylcholine or ACH in the brain, so they're more likely to respond to something like a cholinesterase inhibitor in clinical trials, whereas behavioral variant frontotemporal dementia doesn't respond at all to cholinesterase inhibitors.
Yeah. So it does make a difference, both in terms of understanding the diagnosis and knowing, having a better sense for the family too on how the journey may go. I mean, even though there's some variability for sure. And I think for the medication management, some dementias may have a slightly better chance of responding to medicines like the cholinesterase inhibitors or the CIs. For sure, though, some of the medicines that are sometimes used in the management of agitation, antipsychotic drugs, people with Parkinson's disease dementia or Lewy body dementia may be even more sensitive to the adverse effects from some of those treatments. So again, that would be another reason why it can definitely make a difference what kind of dementia a person is suffering from.
Maybe it's a good time just to mention the different cholinesterase inhibitors because we've been talking about them so much. So there are 3 common cholinesterase inhibitors that we use in clinical practice. One is Aricept or donepezil. That's the trade name and the generic name that you have, and that's a once daily medication, usually around 5 to 10 milligrams. There's another medication called galantamine, or Reminil would be the trade name used, and then finally rivastigmine or Exelon.
And why would somebody pick one of those over another one? Are there sort of preferred approaches?
There's probably more studies done with Aricept than any of the other medications, and certainly more studies done in Alzheimer's disease dementia with Aricept than the other medications. But there's no clear winner that one is much better than any of the others that we can tell.
So I've heard some geriatricians say, these are not miracle drugs, but sometimes I see people in my practice who they refer to as super responders, that there are a portion of people who may have a really robust response. Is that something that you see in your clinical practice, or do you see the sort of super responder?
Yeah, and I mean, I wouldn't call it a super responder. The mechanism of these drugs in our studies, or the way we see them work, is not that they actually improve a lot of people's function. They just mask the deterioration over time.
Might slow the progression. And
so that's the normal case that we've seen across most of the studies. However, when you see a person that improves, and I wouldn't say dramatically, it doesn't reverse their cognitive impairment, but their level of attention or arousal improves quite a bit, I definitely do see those. And more often than not, I'll see those responses amongst people that have dementia with Lewy bodies, especially if they have more of the psychiatric symptoms.
I would agree. The ones that I've seen who have a kind of response, it's probably that there's something else going on that's improved. Either a Lewy body one that sometimes looks like confusion or delirium, or they have like an anxiety or depression, and that improves at the same time.
And I think the challenging part about that is that there's no way to predict.
Yeah.
And the opposite is true, where people will say, well, I don't see a big response in my loved one, but that's not what you're looking for.
Yeah.
You just know that if you studied that person and followed them over time, their symptoms would be better if they were taking the pill versus taking a placebo.
I think it can be a tough and a stressful decision sometimes for families and for the patient about, is it helping at all? Has nothing happened? How do I know? Should I stop it? And there isn't always an easy answer on that. Some of it depends on whether somebody's having a lot of side effects.
And I think, it makes a lot of sense. And we'll counsel people on what they can expect in terms of side effects. So most commonly people will experience stomach upset, so nausea, decreased appetite. Occasionally in severe circumstances they'll have vomiting or diarrhea. There are instances where, because acetylcholine or ACH is involved in your heart rate, when you boost the levels it can slow your heart rate, and people may actually pass out or feel weak or tired because of a slow heart rate. It can cause confusion, right? So it can worsen symptoms in some people and can certainly cause bad dreams in some people. You probably shouldn't take this medication. You definitely should not take this medication if you have an active seizure disorder or active bleeding from your gastrointestinal tract as well. And one thing, I think people will come up against these symptoms when they're first starting a medication, like they're feeling nauseous, or they're feeling an upset stomach, they have diminished appetite, or a little bit of diarrhea. But generally over time, you'll be able to see diminishment of those side effects. So I encourage people, if they're mild side effects, to really try and push through, because they won't see the benefits unless they get through that initial phase. But definitely if you're causing a lot of side effects and diminishing somebody's quality of life for a drug that's not a miracle drug, then you definitely would want to stay away from it.
Yeah. So here's a question. Any suggestions for treating agitation or aggression? Risperidone 0.25 milligrams twice a day and Seroquel 12.5 milligrams twice a day not helping. Also using Exelon patch times for a year. Father is experiencing caregiver burnout with mom and also experiencing insomnia and using mirtazapine 15 milligrams at night. I'm not sure if the father's the one having insomnia or whether that's the patient. And again, we should specify we're not really able to give direct medical advice, but we want to make this more broadly applicable in terms of some learning points. And, of the medicines used, so I guess step one, management of agitation and aggression, non-pharmacologic approaches are probably the best bet. Medicines are kind of a last resort. A lot of them do have risk of serious adverse effects, including death. And so they have other side effects as well. So we don't tend to recommend them. I think it's fair to say too that there's not a ton of evidence that these medicines that we do often use, and you can see this is somebody who's had a couple of trials of different antipsychotic medicines. So both risperidone and quetiapine are two different classes of antipsychotic medicines. So, people use these medicines, even if there's not a ton of evidence. Risperidone would probably be the best evidence medicine, and that's, that dose is not unreasonable. I guess one of the things would be, trying to understand the behaviors, understand the environmental triggers. Those two medicines, I would say, are fairly commonly used, and those are not outrageous doses. So, what do people do after that? Well, sometimes people look at trials of other classes of medicines. If you say, look, two antipsychotic medicines, which are, maybe the best we've got, well, has there been a trial of a mood stabilizer? Has there been a trial of a antidepressant medicine? Has there been a trial of other medicines that sometimes can be helpful with responsive behaviors? So it maybe highlights the lack of there being a clear best evidence approach, that people often try multiple different medicines and in combinations, and that's where it kind of gets messy, because often, there's just not a really effective treatment for it. So not sure if you have any other...
No, I mean, those are two of the common medications that I would use in that setting. I think, though, important along with everything that you just said is to be specific about monitoring for side effects. So it's one thing to put somebody on risperidone, but definitely you or I perform regular physical examinations on our patients to make sure they're not developing the Parkinson's-like side effects, or if they're on a medication that causes problems with electrical transmission in their heart, I am getting an electrocardiogram or an electric map of their heart to measure that on a regular basis. And then always trying to, after periods where things have maybe stabilized, trying to decrease the doses of medication to see what would happen. And in the situation where they're still agitated, you wouldn't do that. You'd probably increase the medications. But just as a general principle, when you're on these medications, which can be harmful, periodically going back and always trying to pare it down to a simpler regimen.
And, if it's not helpful, can we stop it?
Absolutely.
The one other, I want to give a shout out to a common and disruptive side effect to antipsychotics that I feel is underappreciated, and one that I always worry about in people with dementia, and that is one called Acathesia, or restlessness. So especially some of the medicines like risperidone, but really all of the antipsychotics, can cause dramatic restlessness or akathisia as a side effect. This can make the person more agitated. So there's a few different medicines that in the setting of dementia may have a paradoxical or the opposite reaction that you're looking for. And that side effect of akathisia can make somebody internally restless, so they feel they have to move more, they may appear more agitated, they may not be able to express that. So I think that's one of the other important side effects that people need to consider when they're thinking about an antipsychotic in the management of the symptoms of dementia. The other thing that I always get a bit perturbed about is off-label use of medicines for sleep. Now, in this case, somebody's using mirtazapine, which is an antidepressant medicine that has sedation may be a beneficial side effect. So with both the quetiapine or Seroquel and mirtazapine, I notice a lot of people using those medicines now off-label. In other words, Health Canada has not approved mirtazapine as a drug to help with sleep. Health Canada has not approved quetiapine as a drug to help with sleep. All of these medicines have side effects. None of them have compelling evidence that they're great for help with sleep. So I think always be cautious about that. If it helps, great, maybe, but still monitor for, if it's helping and something else that was started, can you come off of it? So
I think it's a great point. And, there are points where you're stuck and you don't have great evidence, but the patient or their family is suffering so much that you have to do something. And in that situation, talking about the off-label use, it's always helpful to have a discussion with your physician about the fact that this is off-label use. This medication, although it's a small increase, does increase your risk of having a stroke or a heart attack or dying. And I always do that with my patients and say, this is off-label, it's not approved. Ethically, we're able to do this. These are all of the risks associated with it, and I'm going to document and tell you those risks. These are the potential benefits that we're looking. These are the steps that we're going to take to decrease the risks of a bad thing that's going to happen, and this is how we're going to monitor for those things. Yeah. So
treat it as a test, a trial.
It's an experiment, really.
And if it helps, great. But if it doesn't, here's our cut point.
Yeah.
Lots of great questions coming in. Question from St. Catherine's. My wife takes 10 milligrams twice a day of memantine. She appears to have stopped most of her anger, but she's still unable to do very simple things. Would an additional type of drug be helpful, or just leave things as is?
I mean, that's a great question.
Do you want to just describe memantine first, because it's not one of the ones that you mentioned earlier?
Yes. So memantine is an NMDA receptor antagonist. So it's different. We talked about ACH being a neurotransmitter and being useful for memory propagation, as well as a lot of other things throughout the body. But NMDA receptor and the glutamate pathway is important in neurotoxicity, so the death of neurons, we think. And by blocking that receptor, potentially we can decrease the amount of harm that the nerve cells experience and hopefully stabilize disease over time.
And right now, memantine can be one of the other effective tools in the toolbox in terms of a cognitive enhancer from a different category. It is not covered on most provincial formularies, to my knowledge. So you have to pay out of pocket, or maybe some people's insurance. So it's less commonly used here. So back to the question, is there any benefit? It sounds like there's been some benefit in terms of some symptoms like anger. Is there any added benefit of adding something else to the memantine?
I think so. Probably what we would consider is adding a cholinesterase inhibitor in that setting. I do question why that wouldn't have been tried. So going back to your doctor and making sure it hasn't been tried already, or making sure that there wasn't a contraindication or reason not to take the medication, such as low heart rate or a heart block or something to begin with. If there hasn't been a contraindication and the memantine has been working, and you really think that the person will have a benefit, or you think there could be a benefit and you're willing to take that risk, then you could do that. But memantine's approved for use in moderate to severe dementias, whereas cholinesterase inhibitors are approved for mild, moderate, and severe dementias. So if you're at the severe stage, the likelihood of you taking an additional medication and all of a sudden going from not being able to do your laundry to being able to do your laundry is really unlikely. So again, we can't give specific medical advice.
But always evaluating the risks of too many medicines, increasing doses versus the benefits, which may not be clinically that big. So it's always important to evaluate that.
That makes sense. So if you're on one medication or two medications and you're a fairly robust person that has a lot of good body mass and hasn't had a lot of side effects from medications in the past, then you can try it.
And I do think, again, back to sort of what we were talking about at the beginning, maybe a few clinical tips, sort of start low, go slow is one of those. And sometimes it might be better to have just one medicine and continue to optimize or titrate or increase the dose. In other cases, if you can't tolerate the higher dose, maybe the low dose of two medicines could be useful, but it's such a dangerous game of having too many medicines. So I would say, on balance, there aren't many people that we see where we say, you know what, you're not on enough medicines. Mostly the issue is just way too many medicines, and maybe one or two were effective back in the day, but who can tell now, because it's just a toxic soup.
Right.
So, okay. So many good questions coming in. Question from Fredericton. Do anticholinergic medications worsen dementia if Lewy body dementia is present or Parkinsonian symptoms? I think the best answer for this is probably yes. So anticholinergic medications seem to be able to worsen cognitive symptoms in people even without dementia. And there are people who have Parkinsonism that might be caused by antipsychotic medicines, one of the treatments for those symptoms, not in people with dementia, can be the use of anticholinergic drugs. So that's a setting where somebody doesn't have dementia, they're given an antipsychotic medicine, they develop Parkinsonism. Anticholinergic treatments can be helpful for them, but those patients may also develop cognitive side effects or impairments from the anticholinergic medicines. And we do see cognitive side effects with anticholinergic drugs in any of the dementias, including Lewy body dementia. And
so you would probably say, 95 times out of 100 or 99 times out of 100, taking an anticholinergic medication in the context of Lewy body dementia would be a bad thing.
Yeah.
Probably
evaluate the risks
right?
and benefits. There may be a compelling reason, but be aware that there's a risk of worsening cognition with any anticholinergic. You haven't mentioned multi-infarct dementia. My father was diagnosed with this after he died from a stroke. So that's multi-infarct dementia is the term that used to be used. We tend to refer to it now as vascular dementia. And as with many of the dementias, in life, the label that we say is, it's possible or probable. So if somebody has had multiple strokes, their risk of developing a vascular dementia or a multi-infarct dementia goes up. Again, some of the medicines that we're talking about now can be helpful in the setting of vascular dementias as well. And as we talk about in our lesson on the types of dementias, good blood vessel health and managing your risks of primary, stroke prevention is one of the best things that you can do if somebody has a vascular dementia.
Absolutely.
Anything else to comment on that?
No, it's great.
Another tough question. Please comment on current best practice deprescribing cholinesterase inhibitors, or CIs, in severe end-stage dementia.
So I think a good starting point for this question is there any evidence that cholinesterase inhibitors provide benefit in end-stage dementia? And the answer is yes, they do. They can provide an improved cognitive score, they can improve behavioral symptoms, and the same goes for memantine as well. The question I always ask myself is, before that happened, I'm always looking for side effects. So if you have any kind of side effect in any way and your dementia is severe, I'd get rid of it. And then when you're kind of in a bedbound state, or you're having recurrent aspiration, or you're experiencing weight loss, and it looks like potentially the cholinesterase inhibitor is impacting your appetite, you have less than a year left in your life or expectation of living less than a year, then also I would get rid of it in that sense. And then you never just get rid of it cold turkey.
Yeah.
Usually you'll taper it down, slow increase up in medications, slow taper off in medications, and then you can observe if the patient's getting any benefit. If you get rid of the medication and there's agitation or increased anxiety, increased calling out, then you could always put the medication back on. But it's worthwhile trying. And I think people get a little bit hung up on this and, I can't get rid of the cholinesterase inhibitor. It's not a life-sustaining therapy. It's not a miracle drug. So be reasonable, responsible, and vigilant around what you're doing. And then you can't actually go wrong in that setting because you're not saving the person's life.
Yeah, I think it's, especially if in a end-stage situation where you as the caregiver or the substitute decision maker, you're trying to make the best decisions to respect the wishes of the person. One of the things that can be helpful in the early stages of dementia is to talk a bit more about advanced medical directives to try to get a sense of what that person's express wishes are about certain types of treatments, vital treatments usually, like would you like CPR? But you can ask some questions early on about, well, what about certain medicines? And, so I think that's a trend now that we're not great at doing is actually end-of-life planning and advanced medical directives and having some of the conversations early on in the stages of dementia can really help the substitute decision maker to be sure that they're acting in the express wishes of that person, so that when the time comes to make a difficult decision and you're evaluating the risks, benefits, and quality of life, you have a clearer sense of what the person with dementia's express wishes or preferences and values would have been. So I would encourage people to look. There's some really good, I think we're probably going to do a live event on end-of-life planning and advanced directives and things like that. But, the more you can talk about some of these challenging conversations early on in the process, the better you can be sure that the values and preferences of the person with dementia are respected later on.
I always tell my patients, they're not easy conversations to have. They're uncomfortable conversations to have. And I think that's why doctors and patients and allied healthcare providers can sometimes be avoidant. But what's much more uncomfortable is when you get in the situation where it's a high stakes game and it's really like life or death planning and you don't have that information. It's much more uncomfortable when you arrive at the setting where you don't know what the patient would have wanted and you can't make an appropriate decision.
And then you have people like me that just show up at cocktail parties and start talking about these things inappropriately. But I think it is really important to have these conversations. We have so many good questions. I'm going to try and keep going to get through them. Some are comments too. General feedback: drug names are difficult to remember. It would be great to have a written list so that we can discuss with the doctor. On our iGeriCare lessons, we do have the written names of some of these medicines, and I totally agree. Not only are there a lot of different drug names, and some of them are difficult, as doctors we invent 2 different names for every drug, a generic and
it's
a
terrible.
trade name, just to confuse people more. So sorry about that, wasn't my idea. But in the iGeriCare lessons, we do often write down the names of some of the longer drug names, and we put both the generic drug name and the trade names. So that's one way around that.
A helpful thing to do maybe is also ask for a blister pack. It's like an easy thing to do where the pharmacist will put all of your medications in kind of a cardboard plastic cutout where all you have to do is pop out your medication for morning, noon, supper, and bedtime. And you can make sure that the patient's taking all of their medications, but at the same time it provides you instant access to a list of almost all the medications. Occasionally there could be bottles outside, but it's an easy way to have a list. Then you just take the blister pack with you to your doctor's appointments, and you can have them explain what the different pills are used for.
Many of the pharmacies now offer either a secure online approach where you can kind of log in and print out your list, or certainly if you go to the pharmacy and request the list, that's always a good.
Yeah.
And many physicians, it's good to bring the actual dosette or blister pack or pill bottles with you when you go, because it's very helpful sometimes just to check what the label is as the healthcare provider.
And I think it's also important if you're the care provider, let's say you're a daughter or a son, when you're going in to discuss medications, because medications can have such profound cognitive side effects. I've had patients where the husband is taking the wife's Tylenol number 3s. And so just finding all of the medications, whether there's empty pill bottles or active pill bottles, a blister pack,
Note to self, the shoebox is not a suitable.
Shoebox.
I
Yes.
have absolutely seen people who have brought in the pills in one big mix, and so dosettes, blister packs, and deprescribing lists.
Yeah.
I'm tempted to make a bit of an executive decision that we keep going and extend this session. Maybe we go to another 10 minutes because we're really at our 45-minute mark. Hey, but caregivers, care partners aren't given training on how to properly engage people living with dementia and how to use non-pharmacologic, non-medication approaches. Let the docs prescribe training for the care partners instead of antipsychotics. And I think that's really part of our role with iGeriCare, is to provide high-quality, online, accessible, evidence-based education for caregivers. We do include conversations about the medicines, but as we've talked about, the most important interventions are non-medication related. So hopefully this service is helping to improve that.
And I think connecting the different services, so definitely we have people that tune in from across Canada and actually the United States as well. And so it's going to be slightly different depending on the jurisdiction that you're in. But let's say, for instance, here we have Behavioral Supports Ontario, which will go into the home and help you learn what you need to do. And there are educational tools for formal caregivers or healthcare providers to learn these as well. And so we don't want to recreate the wheel and create a lesson on everything. We do have some managing behaviors aspects, but also pointing you to the fact that there is going to be something in your jurisdiction which is there to help you deal with behaviors and learn the tools and tasks you need. And whether that's the Alzheimer's Society helping you, whether that's a community care organization that's helping you, I think the question is being able to ask them, you know, what can I use in my specific town or city or province or state to get that information that I need.
Someone reminded me the other day too that the 211 service, you know, we have 411 for information and 911 for emergencies. 211 exists as a service across many areas of the country, and you can dial that to find out about community and social services related to it. They have sort of skilled, trained operators, and many of them speak multiple languages and will provide you an answer on the phone or contact you back with information about community resources. We got to thank you for talking about the fact that antipsychotics can cause the very behaviors they're supposed to address. Here's a tough one. What is the evidence regarding the use of high doses of metformin for what some believe is type 3 diabetes or dementia related to insulin levels?
That's a great question. I don't have an answer for that. I'm not sure if you're aware of this. I know there was some research in intranasal insulin a few years ago to see if changing the metabolic paradigm could improve things, but I haven't actually reviewed the evidence on that. So.
I have not either. What I would comment is I think there's more and more literature now with respect to the potential for cognitive impairments and dementia as a risk, if you like, for people with poorly controlled diabetes, whether it's insulin dependent or not. I'm not really familiar with this notion of the type 3 diabetes or dementia related to insulin.
And it is interesting that something like high blood pressure is a risk factor for vascular dementia, as you would expect, causing blood vessel damage, and diabetes is a risk factor for vascular dementia, but they're also risk factors for Alzheimer's disease. You know, so there is something there, but I'm not sure exactly. And generally what happens if there was a big trial that was practice changing, that was going to have a large impact in changing the course of Alzheimer's disease or dementia related to anything, we would be hearing about it. But we'll look into that and maybe get back to you on in the comments section.
Yeah, so there was a general comment about thanking for answering a question before it was posed, and I guess it was a comment that many patients get diagnosed with dementia and almost immediately prescribed medicines for depression, sleep disturbance, anxiety, and we would certainly say that's not really best practice. So.
Right.
Another question that was a follow-up question to the person who asked about the cannabis for dementia and arthritic pain. What do we think of the concept of sertraline being prescribed for the same patient, the 80-year-old with dementia and severe arthritic pain mentioned above, and celecoxib for pain? What I would say in general is, you know, the sertraline is not one of the antidepressants that is typically prescribed for pain. It has sertraline is also known as Zoloft. It's quite an effective antidepressant for the treatment of depression in general, and quite an effective antidepressant for the treatment of various anxiety disorders. The data to support the use of sertraline and even other antidepressants for the treatment of depression in dementia is not that strong. So again, I would say I'm not hearing a really compelling, in this little blurb, you know, nothing leaps out to me to say, yes, sertraline for dementia and severe pain. The celecoxib is a type of pain reliever that also has potential for side effects, but is sometimes used when, you had suggested before something like Tylenol. The one thing that I would say the best evidence would provide for treatment of severe arthritis and dementia would probably be exercise.
Yeah,
it's about the closest thing we have to a miracle pill. I guess it's there's some data on the use of mobilization, physical activity, physical therapy, exercise. So.
I've been really blown away in my practice, and the people with chronic low back pain that will take their core exercises seriously, and the people with severe osteoarthritis of their knees that will strengthen their quadriceps muscles, which are right here, which offload the pressure and stress across the joint. I think one thing, so most of the antidepressants that are used to treat pain are used to treat nerve pain specifically. Yeah. There's one antidepressant called duloxetine that has some evidence for treating arthritic pain. But again, are you exercising? Are you on regular Tylenol? Have you tried something like Voltaren as an anti-inflammatory? Because none of those have cognitive side effects. Are there potentially that you've been using injections within the joint and seeing potentially a physiatrist for that? But sertraline, I'm not aware of any evidence for treating musculoskeletal nociceptive pain that's not related to nerves. So I don't think that's a good choice.
What about non-pharmacological interventions like music or reminiscence therapy? I think we do talk about that in terms of the treatments for dementia. There's not a ton of super compelling evidence, but there is a little bit accruing. There have been some new studies on the role of music therapy. They're not very high quality studies, but I think the risk of harm in most cases is fairly low, and you could always try them. I think there's not so many studies, but there are more being done on the reminiscence therapy, which is again, I think those things might be worth a trial, even if there's not great strong evidence for it, because the risk of harms I think are relatively low.
Yeah, I think I would add to that scent therapy, aromatherapy as well. So aromatherapy, light therapy, reminiscence training. I find that interesting. Music therapy, I find it interesting that there's a bit of a signal across each one of those different domains, that there are studies and they are showing that there's positive impacts, but they're not high quality. And so I think we've talked about this before, and maintaining a creative approach, because let's say, jazz music might not work for everybody, right? It kind of depends on your personhood before you had
and certain, I can imagine, I have a sensitive smell, I can imagine certain aromatherapy would really annoy me as the care provider, but it might take you a while and some trial and error to find the right type of music or aromas that are helpful.
I think that might be the reason why these studies are hard to do, is because it's not just one easy intervention. So you can try them out, and you said there's little harm in trying them. So
another feedback, thank you for the incredible opportunity. I look forward to these sessions, and thank you. I'm really glad people can join. We try and stick to the 45 minutes, but there were just a ton of really good questions. I'm saving a doozy for the end as well. In the UK, they're using ultrasound for Alzheimer's. Is that real? Nothing's real in the UK, is it?
Well, I think, just because you're doing something in the confines of scientific study doesn't mean that there's a real large impact. And usually what happens is there'll be one study that happens, and then there'll be multiple other studies that happen that will validate your initial approach. And so I don't get too excited. I remain cautiously optimistic, and this has not been translated into
I'm not really sure whether this is part of a diagnostic workup or being used as a therapeutic thing. I mean, I could understand if it were part of a research protocol where you might be looking for vascular lesions as part of an ultrasound of the arteries, or are you aware of some kind of treatment?
I'm not aware of anything like that, or the transcranial magnetic stimulation stuff as well. Right?
Yeah, TMS that's a treatment that's has some evidence for the treatment of depression,
right?
And not so much in the setting of dementia.
But active research going on in these areas.
Final question, and this is a toughie. Well, actually, one comment that came through prior to the session that I think reinforces things. I discovered as a participant in an Alzheimer's study that an unrelated drug I was on was causing brain farts. And I think this sort of highlights what we were talking about. There's a lot of medicines out there with the potential for anticholinergic or other side effects that might worsen memory impairments or other symptoms in Alzheimer's. So very important to look at the full picture, all of the medicines, talk to the pharmacist before you start on an over-the-counter drug, because as we were saying, things like NyQuil, Gravol all have anticholinergic side effects. Talk to your doctor before taking new prescriptions. Ask them if you can come off anything, the deprescribing. Those things are all important to try to minimize the risk of harms. Okay, and our closing. I have a question about aggression and agitation in someone with Parkinson's and vascular dementia. He's refusing meds most days, and when not taking Seroquel, gets extremely paranoid as well. Makes it hard to visit him and interact with him. What can be done since the Seroquel can only be given orally? So, a lot of issues with this. That's why we saved it to sort of do a mini unpacking. Couple things. One important thing relates to consent. So is the person capable of understanding the information about the treatment that's been proposed? Are they capable of consenting or refusing? So the person with dementia, they may have dementia, but they may still be capable of making a decision about whether to take the Seroquel or not. Mm-hmm. So if they are capable and they refuse it, then there's really not much you can do about that other than, try other suggestions or, incentives. You basically have to use other behavioral strategies or abandon those strategies and just say, well, I'm sorry, I can't visit today. If the person is not capable and the substitute decision maker is in agreement that the Seroquel or the quetiapine improves this person's quality of life, it's not an easy thing there, and people are divided on this notion of what we call covert administration of medication, which is whether or not it's ethical to give somebody a medicine if they're refusing it. And it usually only, as I said, the ethicists are divided on this question, but in the case where somebody is not capable, the quality of life seems like it would be improved. The risk-benefit ratio really favors benefit, and the substitute decision maker is strongly in favor of this and feels that it would be, if the person with dementia did have decision-making capacity, they would choose to take the medicine if they weren't incapable. That's the kind of setting where people sort of say, okay, maybe covert administration is warranted if the person can't be cajoled into taking it. So then we have the issue of the route of administration. So Seroquel is just taken by mouth or orally. There are some medicines that have a quick dissolve on the tongue. There are other antipsychotic medicines like that. There are some antipsychotic medicines that are like long-acting or even short-acting injectable formats that can involve a little bit more force. So you begin thinking about, even if it's ethical, I'm not sure that we want to expose the person to that. Could be a bit traumatizing. And some of those medicines that are injectables run the risk of more side effects for Parkinson's. So I think those are some of the things to be considered. There are some medicines that can be crushed up. I think if the decision is made to go forward with some kind of covert administration of something, talk with the pharmacist about whether there's a way to do that with what's worked to date. So some capsule medicines, you can open the capsule, put it on something like peanut butter or toast or jam, disguise it in apple juice. And again, I'm not saying this is simple. It's not. It's a complex ethical issue, and people struggle with this. But if it seems like this is what the person with dementia would have wanted, that it's ethically the things favor that it would have a benefit rather than harm, then there can be some justification on some occasions for that. So very tough question. one of the things that I just alluded to before talking about advanced medical directives, this is one of those areas in some parts of psychiatry we talk about the Ulysses Clause, and that can be something where the person with dementia, before it becomes more advanced, might say, if I refuse this medicine, you have my consent to give it to me anyway, or you have my permission to do whatever it takes to give me this medicine. So that's one of the types of clauses that increasingly people are looking at with respect to advanced directives around some of these specific questions. So I want to thank everybody for joining us on this extended dance version of the iGeriCare live event on medicines and dementia. Fantastic questions. Our reminder that our next event is March 27th, and that will be on the risk of falls in dementia, and we have a special guest star in Dr. Alex Papianou that will be joining us from the GERIS team at McMaster. I want to thank everybody that's involved in our production. Let's thank our sponsor, the Canadian Centre for Aging and Brain Health Innovation, or CABI, powered by Baycrest. We've had support from the GERIS Centre at Hamilton Health Sciences, McMaster University, the Hamilton Health Sciences Foundation, our local chapter of the Alzheimer'S Society of Hamilton Halton, and our team from the Division of E-Learning Innovation. Reminder that we have our survey, which is pinned at the top of our Facebook comments. You get a chance to vote on what topics you want to see and hear in the future, and we have the option to ignore that and do what we want anyway. A reminder that teamwork makes the dream work. I want to thank Stephanie and Mike and Jamie for another great live event. Thank you very much. We'll see you March 27th.